Welcome back to the Neurology 101 series on the ProPA podcast. I'm Dr. G, and today we're wrapping up our dementia mini-series with pseudodementia, a term used to describe cognitive decline secondary to depression. It's not a true dementia, but it can be mistaken for one, especially in the elderly. Let's dive in. Did you know the term pseudodementia was coined in the 1960s? And while it's now considered outdated by many clinicians, the phenomenon is real. Late life depression can cause profound memory issues, often reversible with proper treatment. Let's look at the Kinderpatho. What is pseudodementia? Well, pseudodementia refers to cognitive symptoms that arise from major depressive disorder, rather than primary neurodegenerative conditions. Patients often present with memory complaints, difficulty concentrating, fatigue, and slowed thinking. But the cognitive dysfunction resolves with the treatment of the depression, unlike the true dementias. So, how do these patients typically present? Well, clues that point to pseudodementia include sudden or recent onset of symptoms. I don't know responses rather than confabulation. Memory loss but preserved orientation. Depressive symptoms like sadness, anhedonia, guilt, sleep, and appetite changes. High levels of concern or distress about perceived decline. Remember, it is common in elderly adults, especially with recent loss, isolation, or medical illness. So, how do we diagnose pseudodementia? Well, it's a clinical diagnosis. It requires a good psychiatric and cognitive history. We can screen for this too. We can use the Geriatric Depression Scale or GDS. We can use the PHQ-9 or a mini cog or MMSE, which might show mild impairment but improve over time with treatment. It's important to rule out true dementia, especially early Alzheimer's. You might consider a trial of antidepressants, which can be both diagnostic and therapeutic. Treatment? Well, we want to treat the depression. SSRIs like sertraline or citalopram are good choices. We can also consider psychotherapy like CBT or interpersonal therapy, and lifestyle interventions like social support and physical activity. We want to reassess cognitive function after the mood improves, and avoid anticholinergics or sedating agents that can worsen cognition. All right, book med versus street med. So the book's going to show us an older adult with depressive symptoms and cognitive complaints. Think pseudodementia. Street med, you might have a 72-year-old woman who tells you she's losing her mind since her husband passed. She's tearful, forgetful, and no longer interested in activities. But she's alert and oriented, and acutely aware of her struggles. With the treatment of the depression, she's back to baking cookies and beating her grandkids at Scrabble. Clinical pearls. Pseudodementia mimics Alzheimer's, but the patient often recognizes the problem. I don't know is a red flag phrase for depression, not dementia. Always screen for depression in elderly patients with new cognitive complaints. Treat the mood and reassess. Some cases completely reverse. And consider early neuropsych referral if the diagnosis is unclear. All right, it's time for some practice questions. A 70-year-old man presents with recent forgetfulness. He's alert, oriented, and repeatedly says, I don't know, when asked about memory questions. He is tearful and reports poor sleep. What is the most likely cause? Is it A, Alzheimer's disease, B, vascular dementia, C, pseudodementia, or D, frontotemporal dementia? Well, if you've been paying attention, you'll know that this is C, pseudodementia. We have a sudden onset of depressive symptoms, a lot of I don't know responses, and this points to depression-related cognitive impairment. Question 2. What is the most appropriate initial step in managing pseudodementia? Is it A, donepezil, B, an MRI of the brain, C, start SSRI and reassess cognition, or D, initiate memantine? If you said C, start SSRI and reassess cognition, you are correct. Treating the depression is both diagnostic and therapeutic. All right, so some final thoughts. Not every case of memory loss is dementia. Keep an eye out for pseudodementia, especially in patients who are sad, withdrawn, or recently bereaved. Sometimes the mind remembers how to think again once the heart starts healing. Next up, we're shifting gears to structural brain issues, starting with hydrocephalus. Too much fluid, too much pressure, and what to do about it. If you learned something new today, share this episode with a classmate or your favorite preceptor. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you in the next one.